This is the Owens Recovery Science Podcast.
Hey there, everyone, and thanks for tuning back in to another Owens Recovery Science Podcast. This is Johnny Owens. Before we get into our podcast today, which is going to be a really good one, talk about a really new, impactful study. I do want to put out some really sad news. So one of our early podcasts we did with Dr. Kevin Tipton, it was back in 2018. It was called Stop the Muscle Dump. And Kevin, if you all don't know of him, he's an amazing scientist and researcher, and muscle physiologist, and kind of knows all things protein synthesis. And he was a good friend of mine. We were together at University of Texas Medical Branch, soccer buddies, rugby buddies. He came out of Bob Wolf's lab there, which is legendary with all these other amazing minds. And unfortunately, just a couple of weeks ago, we found out Kevin passed away. Young guy, super active, just shocking to all of us that knew him. And so just want to say, rest in peace, Kevin. It broke my heart when I heard this. And so if you haven't listened to that podcast, I re-listened the other day just to kind of hear Kevin's voice. I still picked up some pearls that he dropped in there, but an amazing guy. And check out that Stop the Muscle Dump. And if anyone needs help during this trying times, find help. It's life's too short already, so we don't want to lose people. So anyways, want to get that sad stuff out of the way and then move into the fun stuff. So we'll roll into another Owens Recovery Science Podcast. All right, welcome back to Owens Recovery Science Podcast, first of the year, 2022. Feels like 2021, maybe better than 2020. I'm not sure. Kyle, what's up, man?
Everything is good out here on the West Coast. It's good. I know this is going to surprise everybody, but it's sunny and like 72.
Nice. Sunny 72. Still wearing your masks out there.
Still, yeah. They let me take it off for the Zoom calls. But
good.
Yeah.
You know what? It would be better if you had it on.
I knew that was coming. That's why I have the beard. You only see half my face all the time.
Yeah, that's smart.
100% of the time, you see half my face.
Well, you've done the flip. As you lose the hair up top, you grow it down on the bottom.
It migrated.
Yep, it definitely
migrated.
Man.
This is how it goes.
Good to see you, man. Our first podcast of 2022. So I'm super stoked for this one because, I'm kind of tired. We always have these guys that are like way smarter than us on the podcast and like way more accomplished than us on the podcast. I'm going through their bios and like his 10-page CV, like, Jesus, how am I going to cram all this in? But anyways, we have a great one today because it's a cool paper. It won an award we'll talk about, and they're doing really cool stuff up there. And so we have Dr. Edward Chang on today, who's from Innova Healthcare up in DC. So if you listen to our podcast, we've had Seth Lee on before. We've done stuff and talked about our work with Robin West. And so Innova is near and dear to our heart, and we love what they're doing up there. He's been at Innova since 2015. He's an orthopedic surgeon. He's also the director of research up there. Associate professor at UVA now, right, Ed?
Yeah, that's right.
Yeah, I saw that last minute. So UVA, also adjunct professor at USHUS, who I used to work a lot with, the military's medical side up there at Walter Reed. And he's checked all the boxes, went to Johns Hopkins for undergrad, did medical school at Robert Wood Johnson, and then did the illustrious Rothman Institute for fellowship, and then the illustrious UPMC Pittsburgh for a residency at Rothman, fellowship at UPMC Pittsburgh. So that meant you were chasing Jim Bradley up and down the sidelines at Steelers games. I don't envy that.
I mean, that's all you do. You just got to, Bradley goes a million miles a minute. You just got to keep up with him.
Not many people intimidate me, except when Bradley walks in and wants to talk to me, and then I start shaking in my boots.
Oh yeah. I mean, that's. I remember the first time I met him. He's a big guy, and he's just like, Chang, get over here. And it was like the first day in the OR, I barely knew what I was doing, and but yeah, he's one of my big mentors, and he's really helped me along my career.
Yeah, he called me last year, and he was basically like, "Hey, Johnny. Jim Bradley here. I'm on today's show tomorrow. I need everything you can do to update me on BFR. Okay, can you do that to me about 30 minutes? Thanks. Bye." It's like everything.
He does that.
BFR. Cool.
He's not a big texter. He just calls, and and I feel like anytime he calls, I have to pick up right away, no matter what I was doing.
Yeah, you answer that call.
Yeah,
cool. And awards too. So top clinical educator at VCU when you were there, and then also top doctor in DC. Nice, congrats, man, in 2019. And then what we're going to talk about today is a paper that you've done, a study on blood flow restriction, which is going to be impactful. It's really cool. Early use of blood flow restriction training with low intensity exercise following ACL improves quad strength and postoperative pain and RCT. And you presented this, your initial work on this at AOSSM. You won the O'Donoghue Award, which is basically the best overall paper for a clinical trial or human trial. So congrats on that. And I'm just going to throw out there, I think we're dominating AOSSM with BFR right now. So Eric Bowman and the KJ guys, they won the CISC Award for their BFR trial on proximal. And then Andy Sheehan, kind of a kickoff for our bigger ACL grant we got. He won the AOSSM Sandy Kirkland grant for his paper on BFR and ACL. So they should just call it the AOSSM/BFR conference now.
Well, and what was the Methodist crew? They got something too, or they got the big media release.
They got the MLB award.
Years ago.
Oh, I don't know that one, but they just won the MLB award for their shoulder paper. Brad Lambert's group did.
Oh, cool.
I don't even know what that award is. So cool. Ed, Dr. Chang, thanks for being on, man.
Oh, thanks for having me. Happy to be here.
Cool. So give us your background. So where you're from, how you decided to become an orthopedic surgeon and kind of what your practice is like up there at Nova.
Yeah. So I grew up in Northern Jersey, just outside New York. So a big, Mets, Jets, New York Knicks fan growing up my whole life, played sports as well. And, I had a lot of injuries growing up and I was always interested in sports medicine, but it really wasn't until I got to medical school. I was really thinking about just becoming a cardiologist. And one day, my first rotation was in orthopedics and in general surgery. And then my elective was orthopedics. And I did not realize that you could just have a career taking care of athletes in sports medicine, doing all the procedures that I've kind of read about, growing up. And so that was kind of my, how it led me into going into orthopedics. And really, it's probably the best decision I ever made because I honestly couldn't imagine myself being a cardiologist.
I'd like to jump in here and say, I know straight away that Dr. Chang is a better human being than me, because in the off air, he learned what a big Houston Astros fan I was. And he just dropped in there that he's a Mets fan, and he did not bring up 1986. So I'd like to thank you, Dr. Chang, for not rubbing it in, because pretty much all my Mets, and I definitely would have rubbed it in. If I had been a Mets fan and you were on the other foot, I'd be like, how'd you like 1986, Dr. Chang?
Well, actually, Kyle, when you were talking about the Astros, I just finished the Once Upon a Time in Queens documentary on ESPN. And they, I was only a few years old when 86 happened, and I just got to rewatch that series. And I actually wanted to bring it up, but I didn't say anything.
Yeah, no, that's what I say. You're better than me, because I definitely 100% would have brought it up.
Well, now I'm pissed that you were just a few years old when that game happened.
I was leaving that alone.
Yeah, I should have mentioned.
We're just all mad now.
Well, I grew up in West Texas in the Podunks, and I'm actually a Mets fan because the only baseball we could get was we got WOR on cable, the New York channel. So the only baseball I could even get Ranger stuff. So I grew up, strawberry. I had a curly kind of. I looked like Gary Carter, my hair, so I was proud to rock that Gary Carter fro back in the day. So
he was my favorite.
Gary Carter, Ray Knight, Keith Hernandez, all those guys, man. Those are some ball games back then. Yeah. So much fun. Can I don't know if a little baseball lore here. I think this was the same year. Do y'all remember Billy Hatcher breaking a bat and the bat was corked?
No.
Do you remember that?
I don't remember that one.
I probably shouldn't tell you on air, but I know who corked the bat. I'll tell you that. I'm not going to tell you actually who did it, but I know the person that did cork the bat.
Well, you can't tease it. Go ahead and drop it, man.
I can't do it. No, it may or may not have been a family member of mine.
Oh, jeez. That's what I was about to say. Someone in your family. Wow.
Yeah.
Chang,
and I learned that very late in life, so it was kind of funny. Yeah.
One day you'll have to let us know.
One of these days. off air.
Dr. Chang, tell us a little bit about your practice. So what are you kind of just one certain region, or is there stuff you like to focus on?
Yeah, so like you said earlier, I'm at a Nova healthcare system in Northern Virginia. So we're just a few miles outside of DC. Actually, I'm in DC right now. And in our orthopedic group, in the sports medicine division, it's great. We have 6 orthopedic sports surgeons, 3 primary care sports physicians, as well as neuropsychologists that take care of concussion. And you mentioned Seth Blees. He's also director of our rehab services. So in every office, we have our PT clinic right there. And, it's great that we get to communicate with our therapist. Me personally, in my practice, I really take care of shoulder, elbow, knee, sports medicine surgery. So the typical stuff, rotator cuff, labrums in the shoulder, and then ligament, cartilage, meniscus in the knee, and then elbow arthroscopy and some medial elbow and throwing athletes too.
Nice. Yeah. If anyone's up in there and they need to see a surgeon, definitely see one of you guys, but also your facility is just super cool. It's you've set it up. It's badass. You got rehab right there, and it's just massive, cool facility. And last time I was there, y'all were just building that outdoor kind of turf field area and all of that. So it's
that's completed now. So it's all up and running, and our patients love it, especially our kids. They sick of rehabbing. They got a 8-9 month rehab in ACL. Get them outside, do some stuff on that turf field. It just does wonders for them. They're just like so much happier when they come back and see me once they're out there.
Yeah, it's nice. So we're going to roll into this study here in a minute.
Yeah.
How did you kind of come up with doing a rehab / blood flow restriction study? Were you already doing some BFR stuff or?
Yeah. So since 2016, 2017, we've had BFR in our clinics, and our patients, and I feel like we were one of the first earlier adopters in our area, and especially amongst my friends, who are all orthopedic surgeons throughout the country. And
you guys were,
a lot of my patients were coming back saying, "Oh yeah, this therapist, tried something, BF blood flow restriction. They just put a blood pressure cuff on my leg, and man, it was hard, but I felt great afterwards, and I feel like I was progressing with strength, because the biggest issue I have is trying to prevent muscle atrophy in my post-op patients. And because all our PT clinics had BFR, it made a study like the one I designed pretty easy to do. And so, and then as I was thinking about it, I talked to Seth about this, and we decided, hey, why don't we just see, we talk about all the time that we think BFR and early postoperative, ACLs would be beneficial in terms of muscle strength. Why don't we just actually take a look at it? And so we designed this randomized controlled trial, and we started it probably at the end of 2018. And we just completed it now. So the numbers that I presented at AOSSM is about double that. So we're just kind of rewriting the paper right now to submit it. It'll have it's a little bit more powered study.
Nice. So I'm excited to see with the new power on it. Yeah. Cool. Yeah, you guys. So 2015 is when we really started ramping up, kind of publicly training a bit. And Seth was one of the first ones. 2016. So you guys, like that first year, really started implementing it. So you were an early adopter, not just up in DC, but nationwide, at least for people who do it through us. So it's pretty cool. Yeah. So one thing on your title I'm going to get to, and it was great reading your paper that you put out there, is early use of blood flow restriction. Yeah. And so I think that's key. And so there's a paper you mentioned in there, and I was kind of involved when they were setting up design at Ashish Betty's, where they did it a little bit later. Mm-hmm. And they used the worst title ever. Blood flow restriction, doesn't work.
Yes. I that paper came out in the middle of our clinical trial, and I saw that, and one of my residents, Andy Curley, he texted me. He's like, "Hey, did you see this paper by Dr. Betty?" And I looked at it, and it, you look at exactly when, they were using it. And it was at the point where the patients were already doing high loads. And, that's where, most of the papers suggest that BFR, is not as applicable. It's more in that early post-op periods when we should be using it. And I said, this is perfect, because our paper is going to be the exact opposite of that. And because we were already starting to see the differences between the subject and control groups. So
I
think the thing that gets lost in that paper too is their heavy load group didn't get stronger either.
Yeah.
Like none of essentially their rehab program that they designed for that trial didn't do much of anything in the time frame that they studied anyway. So it's an important piece that kind of gets lost, especially with the for lack of a better term, the clickbait title that they had.
Right. Yeah. I mean, that's the journals want your conclusion. That's why my title is so, you just read that title, took like a minute on my paper. And that's because the AJSM and some of those journals, they want that kind of, they want that conclusion right there in the title. That wasn't our initial title for this paper.
Interesting.
So yeah. And actually I talked to Dr. Betty at AOSSM back in July, and he was one of the ones that were selecting the O'Donoghue awards, and he said that's exact one of the big advantages of our paper was that we were doing it in that early stage, try to really kind of go right at preventing muscle atrophy from week 1 or 2.
Yeah. And Ashish is a friend, and he's a big BFR guy as well. So it's not like they don't do it there in Detroit and at Michigan. But and in their defense, and when Rian was setting it up, they were already seeing that as at 12 weeks when they were still pushing people heavy, the needle wasn't really moving. So that their point was maybe we'll throw this tourniquet on and it'll give us a little bit of something extra. And so when because at first we were like, yeah, not sure about this, probably not going to go anywhere, but it's like, well, I mean, we're not going to know until we know. And so, we always put out there, BFR is a low load game. It's not made for heavy load. If you're lifting heavy, you're already putting a lot of occlusion on the vessels already. Right. Tourniquet's not going to give you that much difference. And then again, like you said, doing it 12 weeks out is the problem. So perfect on yours for starting early, and perfect on yours for starting low load. So you want to kind of go into a little bit of the design and what your hypothesis was?
Yeah, sure. So our hypothesis was that early use of BFR will help basically slow down muscle atrophy, improve quadriceps strength. That's what we were basically looking at. That was our primary hypothesis. We want to conduct a randomized controlled trial. So basically patients that underwent ACL reconstruction and that wanted to participate in the study were either randomized to get early use BFR along with the standard rehab program, or get randomized to just a standard rehab program itself. And so we had about 35 patients, but 26 are available for follow-up. And what we kind of found and was that patients that had that were using the BFR had statistically significant increase in quadriceps strength as measured by terminal knee extension. And what was really interesting was that their VAS scores at 6 weeks was significantly lower than the patients that did not get BFR. And that was something that I heard a little bit about, but it was really surprising to see that the difference in that.
Yeah, that's something. I mean, if you listen to our podcast, people probably get sick of us because we're so hot on this pain thing with it right now. But one of the guys that we work closely with over in Europe, Luke Hughes and Stephen Patterson, they're really going deep into looking at why are people getting this analgesic benefit. They did a NHS trial over there, an ACL study, and same thing. They saw reduced pain in their ACL patients as well compared to actually a heavy load group. And even they're starting to see some mechanisms here that there's an increase in endogenous opioid production in the BFR group. So that could be why, especially we see an acute response, but it might be this kind of more chronic 6-week kind of change as well. A low load, but you're getting some quad strength back. Maybe they're not having as much pain just gimping around the house and stuff like that.
Right. I mean, we know that weak quads leads to patellofemoral pain, and that early on after ACL, you're already kind of limping around from your surgery. If your quads are weak too, that puts a lot more stress across that patellofemoral joint. And I just think that's a huge deal. Now, when you look at our data at 3 months, they kind of normalize because, at 3 months, most patients are doing pretty well from a pain perspective after an ACL reconstruction. But I mean, I think it's a huge deal that, at 6 weeks that, they're not in a lot of pain. They can, they can be mentally happier. They can work harder on physical therapy. And so, I probably found that to be the most significant finding in our study, because there have been other studies showing the benefits of BFR in terms of preventing muscle atrophy and and also promoting strength and hypertrophy already. So this is just a really cool finding.
Yeah, it's a little extra carrot on top of it there. That's for
Yeah.
sure. And so they normalized in their VAS scores at 12 weeks, but strength was still higher for the BFR group, right?
Yes.
So you still saw that your second go around here.
Yeah. So as when we go all the way out to 3 months out, yeah, strength was higher. Basically from week 6 or 8 on, it was always higher at that point.
Nice.
So that was our hypothesis. We kind of expected it, so it's nice to see that that was validated.
Yeah, it's always nice to see. So Kyle put this question when we were first kind of going back and forth. How did you measure terminal knee extension? And so the way you did it actually was pretty slick. I've never seen using the dynamometer in that way. So I don't know if you want to elaborate, or we can as well. We're right into it.
Yeah, sure. Yeah, we basically placed a dynamometer behind the leg on a kind of hard flat surface, and we didn't have access, to some of the fancy machines, so we had to.
Biodex.
This is Biodex, excuse me. Yeah, and so this is what we use to kind of measure, and there's multiple studies that have been published showing that this is a good alternative to using the Biodex to measure, different types of strength. So that's what we use. We were able to purchase those kind of across the different PT centers where we train, one therapist to be the one measuring the patients.
And that terminal knee extension is, almost more important, especially that first 12 weeks with these ACLs. That's what's really cool, because, probably the most valid way to use a Biodex now is to do an isometric with it. It's 60 to 90, but then you're measuring maybe some strength that way, but how many patients are at 90 degrees knee flexion? You're worried about their strength, but that 0 to 30 is so important in this group.
Sure. And also measuring those patients early on using Biodex, I'm worried about placing stress across the patellofemoral joint early on too.
Yeah. No, this gets around it. It's cool. So I'm going to talk to Andy. We might need to add this into our ACL trial down here. I like it. We do have a Biodex, and we'll be doing more of an isometric and more long-term, but it was very cool. Talking about when you guys started kind of randomizing and enrolling. So it looked like in what I read in your paper, once you saw their incisions were cleared, maybe at the follow-up with you, or maybe the PT saw that, was that kind of your criteria that you felt pretty comfortable to start it?
Yeah, we went through a lot of the papers, and there wasn't any clear consensus on when to start BFR. And then we may never know, but there's some that say we can start within 2 days, and some that wait 2 to 3 weeks. And so again, I talked to Seth and some of the other people about that, and most of our patients are starting rehab within the first 3 to 5 days. That first one is just an eval. So usually between that second visit, usually 7 to 10 to 14 days is when they're initiating BFR, as long as their decisions looked okay. And even then I'll get somebody will send me a picture and see if it's okay to use, maybe just a bloody steri strip, but go ahead and use it.
Yeah, that's kind of, and again, your great use of the term early, that's starting early in most eyes. And, we get that question so much. When's it safe to start blood flow restriction? And so if you ask me, who's been doing it forever and been around surgeons who are used to it, it's like, I don't know, day after surgery, I'm pretty comfortable with it. What a buddy of mine, Proventure, so just did a surgery on my friend who's an orthopedic military surgeon, big cartilage repair, and he's got his own unit, and he's basically starting it already a couple days post this big Macy procedure, and he's comfortable with it. But you've got to get comfortable with it, and there's some things to worry about. And there was Noyes put out an arthroscopy. I don't remember, Kyle, I think he said we started at 6 weeks.
Noise paper. They said 3
well, he
weeks.
put that. He's like, we're going to institute this with everyone at, I can't remember.
Beginning at 3 weeks post-op.
3 weeks. Everyone 3 weeks.
Yeah.
Okay, which isn't bad. We're like, cool. Okay. But then LaPrade put an editorial, and he's like, yeah, well, we start ours like within the first couple of days afterwards. It's almost like, well, we're cooler than you. We started early. So I think as we get more and more kind of safety data and we feel comfortable with it, the number one thing we always say is, is the patient on board? Are you comfortable with it? Is the surgeon comfortable with it? And if they have a pissed off knee or a pissed off leg, they're not going to tolerate it. But I do agree, if the incisions look good and the knee seems kind of happy, it seems safe to go for it.
Yeah, I've been a little bit more and more aggressive on early use of BFR now on my patients. I think the big ligamentous reconstructions, that first visit, I just don't think they're going to be able to tolerate it because their knees still
Tolerance.
hot. Yeah. But if you're doing a standard knee scope or something, or a meniscus repair where you're not doing too much, basically too much, I don't say damage, but you're working around the tissue too much, and you could probably start that pretty early, maybe in that first eval visit, try it on, as long as you got a patient that's, motivated and willing to try it. And that goes to me thinking we also now do a lot of prehab with BFR too. So nice. It's really nice that the patients already know what that is going into their first post-op visit. Maybe that's something that, they can, if they already knew what to expect, maybe they would try it, that first day if they're not feeling too bad.
That's huge. Them already kind of having some context for it.
For sure.
In a prehab. I mean, we saw it in our practice. It just makes a big difference than trying to, all right, I'm going to teach you how to rehab this knee. We're going to kind of work on that. And then also we're going to do this kind of wild thing where we cut off your blood flow in your limb.
Yeah. Getting them acclimated to it's huge. We have a prehab and post ACL trial going on up in Toronto right now. I can't remember his name right. John Delopoulos, the Toronto Raptors doc. They've got a pretty decent sized trial rolling. So it'll be interesting to see, when you see both sides, because there are some prehab studies that have shown some decent stuff, but they've only done it prehab. So then we don't really know what happens post. So it'll be cool to combine those together. Or maybe you guys just need to do the big one up there at Inova.
Hey, I mean, that's something I've thought about doing, is a kind of a prehab post-op type trial. We got to kind of put our heads together and figure out how to actually design a study. But I've been thinking about that for a while.
Nice.
Well, it sounds like it might be challenging. I thought it was interesting that a couple people had kind of crossed over in your study, basically because they kind of saw that this was going on, sort of deal, or what happened there, and how does that complicate doing things moving forward?
It's hard. In our consent form and kind of description of our study, the patients, if they want to opt out or want to cross over to one or the other side, they can. And it's usually the patients not getting BFR, seeing the guy next to them using BFR and being like, I want that, and getting over. And that's happened a couple of times, and it still happened. It still happened afterwards too.
That's a problem.
That's tough. Yeah,
that happened to us. We try to do a 6 month out chronic weakness. So if you were, greater than, I think it was 25% weak post-op ACL 6 months out, we randomize you to BFR or exercises without. And we basically couldn't keep any controls, because they're doing just basically nothing. And then the guy doing BFR is like, oh my God, that was like amazing.
I feel better. I'm doing better.
How bad it was.
We
everyone crossed over. So.
You almost need a different site altogether for your
Well, and then you run into the problem of we're the center for the Intrepid. So we're doing BFR there, but they're at another site. And it's like, well, you had this facility influence and all that sort of stuff. So that's hard too, sending the controls to another place.
Yeah.
So, well, I think a good point too is you didn't mention it's kind of maybe dumb to do a sham though. Because then people, and I've reviewed more of these papers than I like to admit, and that's always something these reviewers put in. Well, why didn't you do a sham on the control group? So, there was this blinding. There's no point to that. And so you kind of want to elaborate on what you guys put in there on that.
Well, in terms of a sham, I think patients will know if they're really, I guess you could maybe, do less occlusion pressure maybe to do it. But, we kind of decided that, that just in terms of enrolling enough patients, it was just going to be a little bit difficult to conduct 3 arms into that study. So I think we just kind of decided this is the most simple way to kind of conduct this, which is to do that.
Yeah, I'm glad you put it in your paper as well. We do have some sham trials. We have a sham ACL trial going on at Rush right now. And basically you inflate it to 20 milliliters of mercury, and they literally have to hold the cuff on when they get up because it's just barely on there. So you're like, ooh, how was that treatment? They're like, what do you mean? This little clothy thing that's on my leg right now? So it makes no sense. You guys took all comers, it sounds like. So hamstring grafts, BTB, So there was no, just one kind of graft choice on this.
No, and again, this is just early on. We just wanted to get as many patients in, with ACL. We
Sure.
depend, regardless of what graft, quad weakness and atrophy is a major problem.
Right.
It would be nice if we had larger numbers and we can maybe do some subgroup analysis, say, hey, which one's most affected? Because my feeling it would be probably the quad tendon autograft set. It's probably the hottest graft right now in the literature. So that would be, something interesting, down the road, is especially, I think, quad ACLs. I think that's the one where, BFR it'll be really interesting to study the effect of BFR on quad rehab.
Yeah, for sure. And you also included meniscus. You had some meniscus repairs in there as well, it looked like, right?
Yes. So we had meniscus repairs, or partial meniscectomies were included. What we didn't include were patients that had a meniscus root repair where their weight bearing would be, really significantly altered, or any type of cartilage work. We just took those patients out too, every patient, we want them to be weight bearing coming out of surgery, just to standardize it a little bit more.
Okay.
You did something I thought was kind of cool, and I don't think I'd seen it before, where you basically, it seemed like you were kind of trying to handicap what the joint looked like to a degree, where you were quantifying the different, compartments of the knee and what the joint surfaces were looking like.
Yeah. Basically every patient that we grade all the cartilage in all our surgeries, and it's just one thing we know. If you have, some degenerative changes in the knee, you're probably going to have a lower IKDC score. You'll probably have a lower VAS score post-op as well. And so we kind of want to make sure that the patients that we were enrolling, there wasn't a significant difference in the degenerative changes that were found in the knee, which was good that we didn't really see much difference.
Yeah.
I made sure our docs, if we ever had some of those, I would get them to our other therapists, that I wouldn't treat them. So, my patients just always kick ass. Oh, you pristine joint? All right, nice. I'll take this one. Special forces guy? All right, he's mine. Cool. So
Johnny has lived a spoiled PT life, Dr. Chang, in many ways.
I haven't written a note in 20 years.
I had so many
military inserts.
So much.
I got really good at just signing my name. That was it.
Wow. I wrote 33 notes today.
Yeah.
We didn't get paid different no matter what, so.
No, that's true.
I would tell my interns, all you got to write is no beta or mo beta. That's it. You can just write no, and next time you come in, we'll just put a line on it. It looks like Mo. So,
gosh.
Getting into your BFR parameters. So you guys use obviously Delphi systems up there. You used 80% limb occlusion pressure. And I know we always kind of have to put that in there. Sometimes you have to kind of fluctuate it with patients, and that's kind of, I'm sure, clinician kind of decision-making, how the patient's tolerating it. You put that in there, and kind of the standard protocol. We just always want to put this out there so people know at 30, 15, 15, 15, which everyone who probably listens to this podcast knows, everyone was done at low load 30-second rest periods. So I think that's pretty much right on, right?
Yeah, that's right.
Right. And I think another thing that was important you put out there, this was early. You basically started them when their incision looked good, and you saw no adverse events and no one drop out because of BFR. Is that correct?
Right. Yeah. We started it as basically as early as possible. Once usually within, 5 to 10 days, they're getting BFR. No adverse effects, no patients dropped out as well. For the most part, they come back and they're like, it kicked my butt, but I loved it. Right. And so that was pretty much the common theme that I got from my patients that were on the BFR trial, or just my patients getting BFR in general.
Yeah. Well, and this is important because, as we're getting into this timing talk, your paper now is showing if you start it within the, that early phase, no issues really at all. Luke Hughes and the folks over in the UK, their NHS trial, they started basically within the kind of same time frame, no issues. The Methodist Houston guys, their paper is about to come out, same thing, started early, no issues at all. So it's starting to look, if we cluster these together and did a meta-analysis, I don't think we're going to see anything other than, even the controls are dropping out more than the actual BFR group is on this. So that's pretty cool to see. Want to kind of go into your protocol. So just, there's going to be a lot of rehab people listening to this. First 4 weeks, you kind of started the basic stuff, quad set, straight leg raises, all the kind of stuff they're stuck doing on a mat, randomized to BFR or not, 4 to 6 weeks going into, once they have 120 degrees range and the good straight leg raise, no lag, going into more close chain, wall squat, 6 to 8 weeks, BFR, deeper leg press type stuff, knee extensions and a kind of controlled range, deeper wall squats, 8 to 12 weeks, and getting more lunges and isolated hamstrings. And both groups did those exercises with or without BFR, right?
Cool. Yeah, and this was designed with Seth. I basically asked him, okay, what are the good exercises that we can use BFR for, and then we just want to make sure that both groups were going to do the same thing.
Cool. And so you looked at thigh size as well, and that didn't seem to change from what you guys saw in this, right? And I don't know if your new analysis changed at all, or if you want to tease any of that.
Yeah, the analysis, it trended towards a higher thigh circumference, but wasn't significant as well. So it's still the same conclusions that we have in this paper, which is a little bit surprising. But again, I think the strength was, and maybe that's because of where we're just using a simple tape measure to do that, and maybe there's more advanced things such as using ultrasound, or I know you had Joe Hart on last time with Springbok, and you use some more advanced MRI tool to quantify muscle volume, and so that might be the best. I mean, I'm sure that's probably the best way to really assess for muscle hypertrophy.
Yeah. Well, you got Robin up there, so she can probably get you some free Springboks. Yeah, she's on their advisory board as well.
Yeah, I think we're just going to blame Seth for not knowing how to work a tape measure, I think is what I'm going to. I mean, I know if it had been me, I am literally the worst person with a tape measure. Like, I know Johnny tells me all the time there's this good inter-rater reliability of circumferential measurements, but not when it's in my hands. I'm convinced, and I'm sure Seth is the same way.
Well, he doesn't know how to convert metric system, over the standard. Yeah. He's like, what's centimeters? He probably just blew it trying to do math there as well. Cool. Yeah. So anyways, kind of rounding back here. Really cool thing to see at the end of this. We can start it early. Basically, just do your standard ACL protocol. This isn't any different than what most people are doing with or without BFR. And you saw terminal knee extension strength basically was better from 6 to 12 weeks out, and less pain, which if you're asking me, those are kind of the two big heavy hitters I would want my first 12 weeks out of an ACL. If their thigh got bigger, that's great, but I would much rather see strength and pain and be better there. So kind of finishing up on the paper there, any kind of last thoughts you want to put in there?
I just think that, there's more and more literature out there on BFR, and its advantages significantly outweigh of any potential disadvantages that we don't really see in terms of adverse effects. And for people that are wondering whether or not they want to implement BFR in their clinical practice or in their PT gyms, I just think that you really want to use BFR early on if you're taking care of post-operative patients. I mean, from post-op day 0, that muscle starts to atrophy quick, and any way you can do to slow down that atrophy is going to be such a huge deal in that patient's early post-op recovery, whether it's pain-wise and function, that I just think that using it as soon as possible. Now the question is, we need to maybe, like you said earlier, publish a study saying when, how soon is soon, and can we do that within the first 3 days, 5 days after surgery, and show that there isn't any potential adverse effects. So that would be probably the next important thing to help educate any therapists or clinicians that are thinking of using early BFR.
Yeah. And what's cool too, I think it's starting to be undeniable that BFR is going to be, when all you can do is low load, the winner for the muscle, maybe even for pain. The new thing too is that we're getting a little bit deeper into it. So Seth Sherman out there at Stanford, they're actually starting it very early and looking at BFR versus controls, and are going to look at what's happening at the graft. And is there any changes? They got some, Stanford, all the freaking money. They got this slick new kind of imaging. They're gonna be able to look at it kind of short term, and I believe more long term as well, to see what's going on, because that's been thrown out there.
Yeah, that's interesting. Can you will that change some of the ability for the graft to vascularize a little bit quicker, and undergo ligamentization, I'd be very interested to see if something would change, and I wouldn't be surprised.
Yeah. What we need first is, we believe it's Jimmy Andrews has put out there, he's not sure what hypoxia does to a graft in the early weeks. Although it's very acute hypoxia, I don't think there's anything that any of us are really that worried about. But we almost need this done just to say, well, look, we're not messing with the graft at all. And it's not like we're seeing all these people doing ACL with BFR or having just these graft failures. So it doesn't look like there's any issue. But then if we can say it's actually speeding it up, holy hell, that's badass.
Yeah.
Cool.
Yeah, that'd be a big win.
Congrats on the paper, man, and the award. I kind of want to segue away from that of other things you're using BFR on. Are you using it with any of your upper extremity stuff, and maybe like a UCL or shoulder at all?
I haven't used it for anything. I know there's some talk about the proximal benefits of using BFR, but I haven't had any experience yet using it. But that's something I wouldn't mind trying to, just have my patients start doing it and see, as long as they're okay trying it. Downstream for distal biceps, UCL, tennis elbow as well. Those are ones that we try. I've been using as well. I don't. My patients, they like using it. I don't know if it. I don't have any good data on whether or not it's actually beneficial, but my patients don't mind using it. But that's what in my clinical practice downstream, I've been using it.
We have a lot of folks who are using it for UCL, especially MLB and stuff like that, and groups like you and HSS, et cetera. They all use it with their elbow guys. We don't have a single study going on right now looking at that. So just throwing a little, bug out there, that's something we get a lot of questions on. We're extra articular incisions and repairs. We get this swelling effect with BFR. So that's one we've been saying, let's go a little slower on those, just because we don't want to dehiss or cause some increased swelling. But that's just one of those where if we could just kind of look at some strength, that would be really fascinating. Getting onto the lateral epi and tennis elbow, that has been something we've seen some really kind of promising results. So that's a group, because I don't know, in rehab, those are patients that you just run away from half the time. Everything hurts. And so we used it a ton. Yeah. So there's several trials going on, and we keep putting in grants in the DoD for one, because we've got a lot of good just kind of clinical data. So we're hoping we get a grant, but that's one of those that, these non-operative ones that I know you guys don't like to see either, Dr. Chang, the anterior knee pains and stuff like that, send those over to rehab and say, throw the tourniquet on.
Oh, yeah. I mean, that's basically what I do. Patellofemoral pain, I tell them, go to PT, BFR, and let's see what happens.
Nice. Cool, man. Any closing thoughts you want to share with us on anything, or how can people find you? I tried to find you because I was going to throw out that we're going to have you on Twitter. You're not much of a social guy, man.
I don't have a lot of my social media is not very robust. I have an Instagram account, Dr. Edward Chang. I have maybe 5 posts, and I haven't posted in months. So you can follow me, but it's probably not going to be the most exciting follow. Twitter is even worse. I don't think I have a single post on. It's been on for like 2 years. So yeah, I don't even know. It might be impossible to find me on that thing.
I don't think you're missing much.
Mine only get good like Friday night after a few bourbons, and then all of a sudden I'm trying to figure out what I actually tweeted that night before. So.
Yeah. I'm just worried I'm going to make a big mistake and wake up the next morning and be like, what did you just post out there?
Why is Dr. West calling me right now?
Exactly. And then I guess final thoughts is that I think BFR early use is great in our postoperative lower patients, lower extremity, especially is my experience. But I think you make the case for upper extremity as well. I encourage pretty sure most of the people that listen to this podcast are, going to be adopters and users of BFR, but the ones that aren't, definitely consider using that in your practice. From a research perspective, which I think is, something that's, near and dear to my heart and yours too, is, there's so much opportunity out there to study BFR in our postoperative and non-operative patients too, because of its low risk, its, ease of use once you're trained, and you can do a lot of studies safely. And when you're trying to apply for clinical trials and getting IRB across, as any researchers listening out there, you can do it. compared to some interventional, some of the randomized control trials we're trying to do for surgery, which is a little bit tougher to get pass across. So lots of research opportunities out there, and it's definitely doable.
Sky's the limit. It just popped in my head. Last thing, those are great points. But and also, how many times a week? Do you remember what you guys did? We get that question all the time. Can you do this just 2 times a week or 3 times a week or a certain amount of visits? I forgot what you guys did.
We did. Our patients were going to PT twice a week for the most part. And so we were trying to do 2 times a week. And now LaPrade published it, in his little arthroscopy article back in 2018. He says, if you're doing, low resistance body weight stuff like straight leg raise, you can do it almost every single day. If once you start to put load on it, he recommends maybe alternating body parts. So you do quads one day, hamstring the next day. But again, the research data really doesn't say how many days you can or can't use it in a row. I always thought, man, it wouldn't be so great if the patient just went home with their own personalized, BFR machine and just do it, safely. It'd be great.
We're working on it. So we just finished a trial with total joints at University of Colorado. So So I mean, if these older total joints took them home, no issues at all. So it's awesome. That might be the future. You guys just write a script and they take it home with them. So it's pretty cool. So
and then they just send Johnny out to the house and Johnny teaches everybody how to use it.
I'm fine with that. Hey, Grandma Smith, you got some cookies here? Cool.
He'll be like
talking to the old.
He'll bring Ben to write the notes.
Yeah. Yo, do you have to do a note? Hell no, I won't go there then.
Mo better.
Mo better.
No, that's all of our trials pretty much are set up at twice a week. And LaPrade's kind of preaching what we preach. If you can't do hardly anything, the more is the better. So if pro athletes college, where you can get them in all the time, get them in every day in those early phases. Most clinics can't do that, but that's what's beautiful about your study, because we get all these academic studies. And it's like, well, they did twice a day, and they did exactly this much load. You got to have a biodex. And, you're like, well, damn, I could never do that. But, everyone can do straight leg raises, quad sets, lunges twice a week with their ACL patients. And if you showed that they can get that, what you found doing that is so replicable. That's beautiful. That's why we love this type of study.
Yeah, I appreciate it. I mean, I just wanted to have a study where this is something that can easily be translated into clinic, if they have a BFR machine. So yeah, thanks.
Cool. Awesome, man. Well, thanks for coming on. I was supposed to be in DC last week for extremity war injuries and the damn COVID canceled it. So next time I'm in DC, let's hang out.
Oh, please do. We're having our annual meeting at Nats Park this year in June. Robin and I are hosting it again. Nice. And so we got great speakers coming in from like Rothman, Dr. Delicato coming from Florida, coming in to speak, and some guys from Stedman too. So love for you to come down. Nice.
Well, I'm not going to share a bed with Ben Weatherford again, like your last conference. We got a 1 double bed instead of 2 doubles. So yeah.
I'm not editing that out. Let's
stay
I think you'll be able to. I'm sure we'll try to find a double room for you guys.
Get Johnny his own room this time.
Yeah, thanks. Awesome. Thanks, Dr. Chang. Thanks for all your great work up there.
Yeah, thank you.
And don't be a stranger, brother.
Awesome. Thanks for having me on.
All right. Thanks, man.
Thanks for listening to the Owens Recovery Science Podcast. Owens Recovery Science is a single source for PTs, OTs, ATCs, DCs, MDs, and other medical professionals seeking certification in personalized blood flow restriction rehabilitation training. Find them online at owensrecoveryscience.com.